Our theme of the meeting is physical activity, improving health and reducing disability. And our first speaker is Jill Whitall, Fellow for 90 from the University of Maryland.
Well, good morning, everybody. Okay. Good morning, everybody. Can you hear me? And thank you, Phil, wherever he's gone, for right in front of me, for inviting me to speak. So I'm going to start with defining health and disability. So as all of you know, The Who, and I don't mean the rock band of my generation, have come up with an international classification framework. And they have decided that any health condition will have body functions, activities and participation, body functions and structures, meaning the underlying kind of mechanisms and impairments, activities are the tasks we might do in daily living, and participation is how much we use these movements in society. And they also like to think about environmental factors and personal factors. So the point of this is to say that they're defining disability as all three of those areas. And health, they're defining as state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So now we're trying to consider mental and social well-being as well. So for me, these are very, very broad definitions. They're almost supposed to be on a continuum. So for purposes of my talk, I'm going to substitute the following definitions of health and disability. Some of you got that. So enhancing health, I'm going to say, is increasing health-related fitness, activity levels, and physiological mechanisms, whereas reducing disability is more to do with increasing somebody's participation in activities of daily living on an ongoing basis. So those are the ways I'm using those two terms in the rest of this talk. So I'm talking about the stroke population, so a few facts. There are 795,000, roughly, new strokes per year in the US. Prevalence in the US is 5.8 million. And this is increasing, not because the incidence is increasing, but because the stroke survivors live longer, and also the medical care is better, so there's more of them surviving. 90% have reduced ability to function. And we know that they present with cognitive and emotional problems and movement difficulties typified by, in the words of the ICF, hemiparesis, variability, sensory loss, discoordination, that sort of thing, so weakness of the muscles. Activities, when they can do them, are very effortful and slow, and participation is very restricted. So these are all data that we know. I just want you to see what a stroke patient looks like. This is a 60-year-old stroke survivor. This is 12 years ago, and then you'll see him do the same task 7 years later. And the first video is way beyond his stroke. Well beyond his stroke. So you can see, I hope. Okay, come on. Yeah, there he goes. Very jerky movements towards, reaching out, trying to grasp the Coke can. Eventually manages to do that, brings it back, and then has a devil of a time being able to release. It's in the flexor synergy, and then he has to continue. This is a test that we use. And he will eventually pick it up. And now you'll see him 7 years later. Much straighter movement, easier grasp, bring back and release. So you can see a lot of improvement. And then this is 3 years ago. Not brilliant, but he does go out and play golf now. So, and this is a result of quite a lot of therapy and being in some of our studies, of course. No. So the point is to say that stroke survivors can improve after this 3 to 6 month plateau, and you can see the plateau, if this is a Bartel index of activities of daily living. Minor impairments pretty much plateau almost after a month, moderate after 3 months, and major after about 6 months, although we don't actually see those data. So the point again of showing you those previous movies was maximizing stroke recovery can take a long period of time, and it usually requires some expert rehabilitation. They are not going to get better by themselves. So, the talk. I'm addressing the theme, and I'm going to quickly talk about the health status of stroke survivors, effects of exercise on health, effects of exercise on disability, and then move into current directions in the field. So, although I've done most of my work on upper extremity, I'm going to switch to something new this time. It's going to be walking, and here's a survivor. You can notice, I hope, her hemiparesis. You can see a little bit of a hip hike. You definitely see some asymmetry. She insisted I took her face, by the way, and I wasn't going to. And you can see how she's holding her arm stiffly. She's somebody who you would describe maybe as a mild to moderate person. So what is the health status? These are data from the Mako lab, which is not my lab. It's in the VA. And he looked at stroke participants and age-matched normal controls. And here you see the VO2 peak, and this is the stroke, and here age-matched normals, much, much better. And the point of these 3 METs and 5 METs, this is defining the ADL range for tasks. So these are metabolic equivalents of tasks. Okay, so you can see that these stroke survivors cannot do a lot of activities of daily living, just regular activities of daily living. And they would be classified by the Social Security Administration as being frail disability level. Now, this group have also seen many other things: altered muscle molecular phenotypes, elevated tissue inflammatory markers, reduced peripheral blood flow dynamics. And these people are obviously very not unfit, I guess you would say. And this low physiological reserve is obviously going to lead to less activities that they can do and less participation in society. So what Mako did was to develop a treadmill exercise training program, and this is one of the first in the country, I believe. And you can see that he does not use body weight support, which some of you may have heard of, and he does allow the stroke patients to hold on. So that's not really that good for improving dynamic balance. But nevertheless, this is what he is well known for. For those of you who might be interested, he had some criteria that they had to do. They had to be able to walk a little bit. They had to have some tolerance of treadmill, and they had to have this exercise stress test before we would allow them to go into these exercise programs. And the protocol was based on Carbonen, is that how you say his name? And starting off at 40% heart rate reserve and moving to 60%, and then in his later work he's done 60 to 80%. The data I'll show is using the lower range. And the target is 40 minutes, frequency 3 times a week, and duration 6 months, which is quite long. So let's answer the first question. Does it enhance health and reduce disability versus a stretching control group? Here you'll see data from the 6-minute walk, yes, 6-minute walk. And these are change data. So clearly the treadmill training are significantly better by 3 months and remain so by 6 months. And the stretching group, not surprisingly, does not really gain much in terms of this endurance test. Although we might want to know why they actually did gain here. But we have some thoughts about that. And then in the peak, VO2 peak, those obviously also improved in that group. So, exercise improves ambulatory function and cardiovascular fitness, so we know this. And it also improved glucose tolerance and insulin sensitivity. This same group have done some strength training with these with stroke patients, and it will increase their strength. So in other words, these people can easily be elevated from a health perspective. But does it reduce disability? And the way I'm defining disability, we can ask questions like, is participation in society increased? You might look at that by using sensor data. You put sensors on their legs and you tell them to go off for a week and then come back. Or some questionnaire data. So another thing you would want to ask is walking faster or walking longer sustained over a long term? The short answer to this is there's little evidence that this happens. And I know this from our group, but there are other groups that will say the same thing. So why? Why does this treadmill training, this physical activity in an exercise form, not improve disability or reduce disability? Oh, this is not working. Here we go. So what does treadmill training not improve? Well, here's somebody who is walking along the just floor, and you can see the step 2 pattern, very hemiparetic, and then 5 minutes later, she's on the treadmill. And now you can see much more symmetry. Okay? So we have a couple of publications on this. You know, the treadmill makes you more symmetrical. But of course, what we didn't do was then put them back on the floor. And we know now that we should have done that because they immediately go back into the asymmetry. So this has led to a couple of, this has led the field into a couple of different directions, but the main direction is to do with what we need to do is look at the underlying impairments now. We wanted to look at the quality of the movement and make them more symmetrical, for example, or less variable. So one of the ways people in the VA are doing is using modular ankle robotics. This is an MIT robot, and basically what they're doing is looking at the intralimb coordination on the impaired leg and trying to improve it. And they might do things like help dorsiflexion so that they don't scuff. Another group, this is a shameless promotion, by the way, of Baltimore. Not my work necessarily. So this is across the town in Johns Hopkins, the Amy Bastian lab, where they use split belt treadmill. And this is where you have the belt is split and you have one going faster than the other. And if you and I were on that, we were on there for, say, 10 minutes, and then they switch it back to normal, we would show this after effect where we walk asymmetrically. And then we'd come back to symmetry. And with the stroke patients, they actually do the reverse. They sort of obviously start with asymmetry, but then when you take the, well, I'll show you. I'll show you with the next slide. So what we've done in our lab is to use a weight rather than a treadmill. These are low-cost ways of doing this kind of thing. So you can see here the weight is on the shank, and it's on a pulley system, 1.25% of body weight. And we look at the baseline data, we look at the immediate, what happens when we put the weight on immediately, and then after they've adapted, and then when we take the weight off, and then after they've de-adapted. So here's an example of, this is one patient, the control. This is a symmetry index. So symmetry index we expected to be 0. And this is the control, and then immediately the weight's put on, there's a push away, and then the person adapts and comes back slightly above 0. And then when you take the weight off, there's a negative after effect, and then they come back and basically should go back to 0. This person is slightly above 0. I hope that didn't stay. And then the same thing happens when you put the weight on the unperturbed, the unparetic, non-paretic leg for the stroke patient. But look what happens if you put the weight on the paretic leg. So here, they're obviously not at 0. They have this big kick up, and then they move into 0. And then after you take the weight off, they have a negative after effect, and then they stabilize back to where they were in the past. So one of the things we said with this is actually stroke patients can adapt, because this graph here, looking at all those points, all it says is that there is a difference in each of these points on the symmetry index, but there's no difference between the stroke patients and between the controls. So we know that stroke patients can adapt. And we've worked, and we did another study where we compared adaptation rates. So we thought, well, we're getting this new sensory motor mapping. So, how long does it take the stroke patients to get this? And how long does it take the controls? And they're about the same rate. But if you take them off the treadmill, once you've taken the weight off, and you put them in a wheelchair, wheel them to somewhere where you're going to look at the gait, they show this after effect. And the big good news is that the stroke patients take longer steps to de-adapt. So that might mean that we might be able to push them into a more symmetrical gait if we did long-term training. Does that make sense? So we are working a little bit towards that goal, but the one I want to talk about most is, very quickly, is one more method, which is another low-cost method, which is using rhythmic auditory cueing. So we put a beat on, and we ask them to time themselves to the beat. So obviously that's very symmetrical if it's a symmetrical metronome. And we can attack both the intra-limb and the interlimb, some of the interlimb issues at the same time. So here's our question. Can we maintain the health benefits of treadmill training, because we know treadmill training by itself is good, but also target changes in both interlimb and intralimb coordination and facilitate the transfer to overground walking and retention? So these would be really good things to be able to demonstrate. The variables we used were preferred and fast speed walking as our health-related fitness variables, and 6-minute walk for endurance. Those are pretty standard ones. And the coordination variables, step time symmetry, and stride time variability. Stride time variability is an important variable because it's been shown to be related to falling in many populations. So here's our little design, pre-tests. We have them do treadmill training with rhythmic auditory cueing, or we have treadmill training without for 6 weeks. So not, then we have a middle time where we're going to test them again. And then we have overground training with rhythmic auditory cueing and overground training without. And then we have post-test. That makes up 3 months. So that's 3 months, not 6 months like the other people were doing. Or rather like, Mako's group did. And here is an example of a patient on a treadmill. We do have him suspended here. Not suspended, but for safety harness. And we have a dynamic cane. What we try to do is to bring their hands off the railing. But frankly, that is hard. They really like that railing. But then they don't have a railing for the next part where they're walking around a track. We have the same cue on for the beat. They have the cue. We try to keep the speed the same. We know what speed they're doing. We can judge that, and we try to keep them up with the same thing. And then this is just showing you the gait mat and the same patient being tested after. He's tested 4 times, of course. So what happened? This is a very small pilot study. So if we, both groups would have expected to show these health benefits, right? So we combine the two together, and here's the outcome. This is preferred speed, and there's significantly different from baseline by the time they've done their 12 weeks, and it's retained. Fast walking gets there even earlier, and it's retained all the way through, and the endurance is also same thing, retained. So it seems like we may have something that is, well, we already know that treadmill training does all these things, but at least we've now shown that these can be retained, and we think that might be to do with the fact that we're doing overground training as well as just treadmill training for a variety of reasons. And these are classified as substantial gains by Pereira, rather than sort of gains that aren't really clinically meaningful. But the big question is, have we changed the underlying body function coordination? So because this is such a small study, we're using sample size estimates for the between group differences based on the pilot data. And here are our measures. So if you follow down here, this is the RAC group, this is the control group. And these, all the way down, the RAC group has better changes than the control group. And here's the Cohen's D, and here's the number required to show that in a larger study. And for retention, things get even better for most of these. So we're feeling that these data are sort of, they're obviously unpublished, but that they show some promise, that we could perhaps use this. Now, we haven't shown that we're getting these peak VO2 changes or any of the underlying muscle or glucose sensitivity and all those kinds of things. We haven't shown those physiological changes yet, and so in a bigger trial, that's what we'll be adding to it. And we haven't shown that they do participate more in society. And one of the reasons is that we find those measures a little, well, difficult to use. and we actually think maybe we should be designing a new test, but that's another story. So I think it's time. So good. It's actually time? Okay, great. So I will leave you with a summary of everything I just said, and thank you very much.